First of all, when we talk about non-Hodgkin lymphoma, of course, we have to take into consideration that we are including here many different histologies, and each one of the histologies has its own standard of care regarding first-line treatment and, of course, second-line or third-line treatment strategies. In principle, chemotherapy, together with monoclonal antibodies, when we talk about B-cell non-Hodgkin lymphoma, is still the standard of care. But we are seeing in first-line treatment the inclusion of new drugs. For instance, if we talk about diffuse large B-cell lymphoma, we know that data coming from the POLARIX trial indicate that the inclusion of polatuzumab vedotin in the R-CHOP or CHIP combination is able to significantly improve progression-free survival over R-CHOP alone, which has been the standard of care for many patients and during many, many years, and it has not been removed from this condition by other new drugs in the setting of other prospective clinical trials that have resulted negative. So maybe when we talk about first-line treatment strategy, we are going to see some changes with the inclusion of novel therapies or targeted therapy. If we go to the relapse setting, probably the changes are significantly higher or wider than in first-line conventional strategies. For transplant-eligible patients, autotransplant has been the standard of care for those patients with primary refractory disease and relapse disease since the data coming from the PARMA trial that was published in 1991 or 1992. And nowadays, we have information regarding the possibility to substitute autologous stem cell transplantation, and here we have the role of two different anti-CD19 autologous CAR T-cell constructs. So Axi-cel and Lysocell have demonstrated in ZUMA-7 and in Transform respectively that they are able to give better event-free survival than the standard of care for those patients that are transplant eligible if these patients are primary refractory or have an early relapse. So I think that in the next few years we will be seeing that autologous stem cell transplantation is going to be progressively substituted by the use of CAR-Ts in these specific subgroups of high-risk patients. And if we go to the third-line setting or plus, here chemotherapy is, let's say, leaving its own space to what we could consider new drugs. We already have the indication for autologous CD19 CAR T cells in third-line setting for patients with diffuse large B-cell lymphoma. We can also include here mantle cell lymphoma, where brexucabtagene is approved for those patients with relapsed refractory disease and that have already failed BTK inhibitors. And of course, we have new drugs, still not yet in the market, at least in Europe, but hopefully they will be coming pretty soon, like bispecific monoclonal antibodies that have demonstrated to be also very effective in the treatment of relapsed refractory diffuse large B-cell lymphoma, and also maybe with less evidence in terms of number of patients in mantle cell lymphoma and in other indolent lymphomas. And of course, we have small molecules, we have lenalidomide, we have tafasitamab, and we have other antibody drug conjugates that are not being reimbursed in Europe outside prospective clinical trials, at least some of them, but that have demonstrated to be very effective and with a very interesting toxicity profile, and in some ways will be substituting the conventional chemotherapy in the way that we have been looking at it and we have been using it for many, many years.